Good evening, everybody, and thank you for joining in for a wonderful, sizzling discussion where we have a cross panel of leaders today from healthcare. And as Thankam says, they are all heroes and heroines and stars. So, very warm welcome to all of you who are joining in, and to our panelists who've taken time out from the very busy schedules to be with us today to deliberate on this very contentious topic. We know this is the theme, the theme for this year's Nursing Day is economic power of care. And Nurse India and along with Thankam, we figured that, this is a topic that needs discussion and that needs discussion with representation from, really as many functions as possible. So a very warm welcome once again to our esteemed panelists. We've got representation from really most of the healthcare functions. Dr. Vivek Talaulikar from IHH Healthcare India, Saino Thomas from American Oncology Institute and Citizen CTSI, Devanand Kolutodi, Regional CEO, AP and Telangana, Aster DM, Bindu George, CNO from AIG Hospitals. My name is Indrani. I'm the co-founder of Nurse India. And in an earlier avatar, I used to be an HR leader for various groups, including healthcare conglomerate. And of course, today's discussion will be moderated by our star facilitator, as I like to call it, our one and only Thankam Gomez, founder, CEO, Signia Healthcare, and partner Nurse India. So we are very, very privileged to have everybody in. Before I hand over the mic to Thankam to introduce the panelists and carry the discussion forward, I will take 2 minutes because we've been getting a lot of queries on what does Nurse India exactly do. We keep seeing a lot of Nurse India on LinkedIn, but what is it really into? And I thought I'll just spend 2 minutes on that. Nurse India is, as we like to call it, India's only tech-enabled and largest nursing community platform. Uh, what we want to do is our mission is to make Indian nursing a profession of choice. Indian nursing is valued globally, but in India, we believe there's still a long way to go for nursing to really take its place in the sun. And that's where all our efforts are. We welcome anybody who is a nursing professional, whether you are a nursing leader or a team leader or or a patient bedside nurse or even a final year nursing student. We welcome all of you to join our community by signing up on nurseindia.org. Sign up is free. We also welcome all hospitals and healthcare entities to actually start joining the community and posting their jobs or looking for their skilling functions, as we like to call it. And that's what the background on my background says. We are a one-stop shop for nursing in India. So, without further ado, I will hand over, but there's just one announcement that I do want to make. Many of you would be aware that Nurse India, in partnership with Thankam and Signia Healthcare, we've been running quite a few digital leadership skills bundles. And we've already had interviewing skills, we've had communication skills for nurse leaders, which is currently on, and which we are really scaling up also with SET's help. And our new program, this is again Thankam's signature program, is analytical skills for nurse leaders. This was a key area that we got a feedback on from our community that, why don't we run an analytics course? And Thankam's signature program was already there. It's called Calculations and Numbers Demystified. So we've just launched this yesterday in partnership with Thankam, and what we are offering for all webinar attendees today, nursing professionals who are attending today. And if you are interested in taking this bundle of 6 online classes, 2 hours each, total of 12 hours over possibly 4 or 6 days, we are offering a very special 20% discount for our nurse community members and for attendees to today's webinar. So make sure that you can maybe you can just take a screenshot of this or click a snap of this if you need to. But you can, after the webinar, if you're interested, you can just drop us an email at connect@nurseindia.org, and or you can drop us a WhatsApp at that number there, 62922 88738. The reason we are offering this very special discount in today's webinar was because of the huge link, nursing, the economic power of care. And today we are discussing the value creation, the economic value creation done by nurses in corporate hospitals. And we thought that this topic is really in sync with all of this, and therefore we are very pleased to offer this. So that was, if you all have already noted down the contact number, just an email, drop us an email or drop us a WhatsApp. Without further ado, may I hand over the mic to Thankam to take proceedings forward and begin with the introductions. So I'll stop sharing and hand it over to Thankam. Thankam, you're mute.
I always forget to do that. So, good evening, everyone, and a very, very warm welcome to this very exciting session. I really don't know what's going to happen in this webinar. I really have no idea because this is the first time we are trying to touch a topic which is little bit of sentimental when it comes to talking about it. You know why? Because nurses have always been seen as a cost center. So I am not going to divulge any more secret around this because it is all going to come out from the panelists. I only have some hot shot questions for them, and let's see where we go from there. So let me request all my panelists to come on the video, please. Thank you, Bindu and Saino also, please. Yeah. So, ladies and gentlemen, I'm going to pin all of them so that if you want, you can also pin them on the screen. So if anybody else, you know, joins or they open the video, they'll not be seen. You will be able to see the panelist well. And yeah, you have all the four. I can see all four of you very well. So, can you, especially a very warm welcome. All of you are, here because you all agreed to come and discuss on a topic that is usually not discussed. It's usually discussed in many forums, but in a very superficial and subtle manner. So here we are going to have candid conversations. Candid means anybody can be. So Bindu even asked me, can I be candid? I said, of course you can be candid. I know also, and I said, you be candid as possible. Now, I am not very sure about Dr. Vivek and Mr. Dev, how candid they are going to be. I have no idea. So let's hope that everybody will be candid because nobody is holding any knife on anybody's head. We are all aspiring for a better healthcare. I mean, that's the agenda to understand that how can we, have a better future in healthcare. And because nurses are the majority stakeholders in delivering the healthcare. So then there are some challenges around it. But before we get into the discussion, I am going to request my dear panelists to introduce themselves. So as Indrani already told, Dr. Vivek, Bindu, Saino, and Mr. Dev, very, very well balanced. 50%. I usually call it India Pakistan. So 50% male and 50% female, very well balanced. Didn't happen by purpose. It just happened. I just noticed, I said, oh, wow. Not all nurses, not all females, not all males. So we are doing a great job, Indrani.
Thank
So,
you. It's a very inclusive panel.
so great. So I will not say ladies first. So I'm going to say gentlemen first. Is that okay with the ladies?
Absolutely.
Yeah, so they're okay. So we want to say, okay, we are okay, fine. Okay. Who goes first? Dr. Vivek, yeah, Mr. Dev.
I'll take it up. Thanks, Thankam. Thanks, first of all, and Nurse India, Indrani also. Thanks for inviting us for this panel. I'm actually privileged to be a part of this esteemed panel here. And nurses have always been my strongest support. So I would love to be there always at the back so that they always can deliver. And ultimately in their success lies our success. So I'm looking forward for this panel discussion with great hope.
Great, Dr. Vivek. That's a lot of positive strokes over there. So you are gaining brownies from the audience already. Isn't it? He's already on our side there, so that's good. So let's see how does the panel go. So over to Mr. Dev.
Yeah, good evening. Thank you. Thank you for having us here for this very interesting session. I'm also here to learn and understand the perspectives which has emerged, but I'm a little worried. I think the group, even though panel has two male members, I can see the whole participants all females, but I'm happy that a lot of my old colleagues have joined. So I think I have some support from them. So I basically handle the Andhra Telangana cluster for Aster DM Healthcare and have been with Aster for the last 15 years.
Oh,
And nursing always, for any administrator, nursing is a very, very important department which takes the hospital on its shoulders. But yeah, more discussion can happen during the panel. It is better, but then I think it'll be a very candid. The discussion is what I also expect. That's what is required. It's a very, very sensitive topic that you've selected. So I think it needs to be discussed in that seriousness. Thank you.
thank you. Thank you, Mr. Dev. Over to Bindu.
Good evening, everyone. Thank you, Madam Tankam and Ms. Indrani for inviting me into this panel. And this is a hot topic for all of us. And I have not spoken about this topic. So thank you. And this is my first experience going to be talking economically about nurses. So I am working as Chief Nursing Officer at AIG Hospitals, Hyderabad. And I have been an academic nurse for, 1.5 decades. And then I moved from academics to clinical administration. And ever since I moved, I have understood this side of the coin as well. So looking forward. Thank you.
Thanks. Thank you. Thank you, Bindu. Last but not the least, Simon.
Thank you so much. Good evening, everyone. And I really find this occasion, this platform to be a privilege to share with all eminent personalities here. Firstly, thank you so much, Nurse India, Ms. Indrani and Tangam ma'am for choosing me to be a part of this panel. Very, very important perspective to look at, and I'm sure that all of us are going to learn. I'm looking forward to learn. I'm currently associated with CTSI, a Siemens company, as a Group Chief Nursing Officer for Citizens and American Oncology Institute. So over to you. Thanks.
Thank you, everyone. And Dr. Vivek, I have known him for many years, decades, as he says. So very happy to have you here again, and a very warm welcome to this panel. And Bindu and Saino, I have known you for some years, I don't know how many years, and very happy to meet two young, bright minds who are leaders. Already I know the Indian healthcare is growing and it is changing. So when I see people like you, I know there had been some progress in nursing, some progress, and there's much that can be done. So I'm very happy that you both are here, and a very warm welcome. And as said, I hope you will be as candid as possible. So I need to admit, when you work in a system and when you have to talk about something, sometimes you start thinking, boss kya sochenge? I said it's a candid conversation, right? So boss kya sochenge? Ek problem रहता है इधर सर के ऊपर. Oh, why did you talk like that in such a public forum? So while I admit it, but I think it is now time sometimes to talk about the real need. What is it required? And India is a very large country, and we know that everybody cannot do everything, so but we need to do some things in the capacity that we can. So Mr. Dev, a very warm welcome. I am meeting you in first time, I guess. I am not sure whether we met earlier, but yes, I know Aster for sure. And so I request both of you, both the ladies and gentlemen, to be having a candid way of answering the questions that I'm going to put in, and no need to be very academic or anything like that. I'm sure you must have done few things in your past, and Bindu and Saino might have experienced that in their own system, but it's more important to look at what is not right. That's what I would say. What is not right? What is right is right. It's nice to talk about it. So maybe when you talk about what is right, people sitting here who have not had that privilege of what is right, they can also think of putting those things in place and then uh, talk about some aspirations that we can have in our healthcare system to get the best out of the nursing workforce. Because I am very, very sure that the best is yet to come because we talk about empowering nurses, but we talk. So, walking the talk is very important. So, are we ready for hot, and candid conversation to all my panelists? Okay, great. So I have definitely written some question. Otherwise, I can be lost all over the world and I can take you for a ride for 6 hours. I can ask a lot of questions. So I am being little smart and I am going to ask some questions which I wrote it down. So first question goes to Mr. Dev. So from the time I know, nurses have always been treated as cost center. Even though everyone admits without nurses, no outcome is going to happen. I have had this conversation with doctors and administrators, and has that perception changed? Yes or no? And if it is yes, how did that change? Would like to see
Oh,
from.
very, very tough question in the beginning itself. But yeah, but as I promised, this has to be a candid conversation. So I would say the perception has changed. I would say no. Why? Why? Because of the fact that the nursing is still in vast majority of. I'm talking about especially our country in perspective. Okay, I'm not talking about other countries, but in terms of India, when we look at it, even now nursing is considered as a cost center, but change is coming. There are certain positive elements which has come in. A lot of organizations have started looking at that particular aspect of nursing being so much contributory to the organization. But the overall perception about nursing being a cost center is only because of the fact that you are the largest workforce. Obviously, nursing is the largest workforce in any hospital. So when it comes to the EBITDA, which administrators are obviously, I think you are also taking up that financial calculations, which I'm very happy to see. That's where, a lot of nurses actually don't really, indulge in understanding the ratios of the hospital. So which is a very, very welcoming move by the Nurse India. So when it comes to the EBITDA, obviously each line item, right, comes as a cost. And the HR cost, if you look at it, you dissect the HR cost, nurses cost will be the major contributor. So if you ask me as a person, yes, I'm not as strong proponent of considering nursing as a cost center, basically because nurses, I feel personally, as a very contributing workforce towards the hospital. That has been throughout the last 15 years I've been working like that, and bringing the nurses to the forefront. That's what, not only me, Aster has a practice of doing that. We have had fantastic leaders in nursing. A lot of people are occupying higher executive positions also, not even nursing. They have gone beyond and grown beyond that. So the perception, yes, it is changing. But if you ask me, the entire India has not changed. But the perception now is changing because of the fact that the India itself, or the country itself, is moving towards more demanding, customers. In terms of a value system that we are looking at now, a lot of insurance patients coming into the force. There is a lot of demand from the customers. Even a cash patient demands. So obviously, when demand comes in, unless until the quality of care is really taken care, it's going to hit us in a big way. So now administrators are looking at options, including me, looking at options on how to make the customer happy so that he comes back and I can retain them. So to retain them, the only way is to give them a best care. So today, actually, our Nursing Day celebration got a little delayed. It was happening today. So I was telling my nurses that, I met a patient during one of the travel. He stays about 100 kilometers away from Hyderabad. And he comes to a particular hospital, not my hospital, good for another competitor hospital here. But then the fact that he mentioned was that he travels every week 100 kilometers to this particular hospital to get dialysis done. It's not because the dialysis is not available in his city. It is not because of the doctor. It is not because of the facility that the hospital provides. It is only because of a nurse in the dialysis center. So that was a big statement by a patient, right? Who feels that care is much more beyond than what all other things can provide. So one single nurse who treats him as his own father, her own father, and gives that comfort care. That's what he's traveling for. So that's the power of a nurse, to attract and retain patients. So that is something which I think most of the administrators, the industry has really realized. But yes, when we say, like you mentioned, we do more of preaching. We don't really practice what we preach. In terms of, I mean, I would be very maybe making a big statement. Yes, if you ask me whether the nurses are being paid, according to the kind of work they are doing, if you ask me personally, I feel it is not. Okay. Because but there's, of course, as an administrator, when a lot of other challenges are there, you have to meet both ends and drive the organization in terms of financial feasibility. Yes, we have to make a compromise. But if you ask me genuinely, not even a single administrator, I'm 100% sure, including Dr. Vivek, would definitely agree that nurses, we all feel that should be paid more. But yes, how to do that is the question. That's a big question that we are all that's a big dilemma of any administrator. But now the contribution of nurses, I'll just end with this statement in terms of improving the satisfaction, reducing wastage in terms of that the material usage, right? If the nurse is really capable, they can save so much of money for the organization in terms of leakage or wastage. In terms of hospital acquired infection is another thing where complications can be reduced, and again patient satisfaction can come in. So and patient education is another major area where nurses play an important role. So all this actually contribute in a way to the hospital's bottom line, and also supports in terms of revenue by patient retention. So I think from the cost center to a value added department, that transition is happening, but is a bit slow at this point of time. So I would take a break here, and more we'll discuss. Thank you.
I think you have been very, very candid, and thank you for that candid reply also. The problem still remains, how do we make the Excel work? Okay. So I'm not very sure whether we can discuss how to make the Excel work. So I'm going to quickly move over to Sino and ask that, from your perspective, what are the key challenges nurses face in contributing to the economic success of the corporate hospitals? Because when we talk about, economic success, like Mr. Dev mentioned, they can, prevent leakage and, then do the billing rightly, prevent, wastage of material. There are many things that they can do. Or is it because, that they are not aware that it is their role? Because in my personal experience, when I do all these trainings, I find that there is a lack of awareness, how much of, economic power they really have in hand. So with that, I would like to pick on your thoughts that you think that this can be addressed.
Yes, I think the question in light of Dr. Dev putting a lot of emphasis and highlighting on the points which he has also answered a bit of my questions. Thank you so much, Dr. Dev. Definitely, these challenges do exist in light of how a nurse is being paid, how much strong they economically feel when it comes down to their packages. But I will try addressing this question from the perspective of the corporate hospitals getting benefited through the insight of a nurse. Now, whether it is a slowdown or increase in attack, or whether you look at a waiting time, or we look at minor stoppages or an equipment failures, it could be a wastage at any level, resource or time, in terms of inefficiencies, in terms of source of a poor quality, or the frustration that they may have due to the delay in the maintenance and coping up. Where does it come to? Is it the top management that they are aware of, or is it the middle management? No, of course, it's those frontline nurses who are aware about everything happening in the hospital. Now, when it comes down to the economic power of nurses to contribute to the hospital's progress, I would like to bring and talk about a concept known as the iceberg of ignorance. Now, in the business phenomena, this describes a situation where a large percentage of problem is known to the frontliners, but only the 4% of problems get highlighted to the leaders. So the top leaders could always see only a little bit of the existing issues, because that's something which probably gets lifted up. They may not get the complete view around it, so only 4% of the challenges are known by the executive. So this is the tip of the iceberg that is like viewed by them, right? So what is the challenge here? The important insights which the nurses have, they will never reach to a level where it can be addressed. So that's I think the major challenges. You may know all the problems, but these problems sometimes may not reach where these problems could be addressed. And that leads into how the lack of decision making, or leading into a decision which is an uninformed choice, or it could be a missed opportunity by the leadership, and it will all lead into a cost-centered perspective to the organization as a whole. Now, how can these challenges is the major challenge. Now, it comes down to all levels of whether it is about inventory, whether it is about the time management. If a person knows the problem, probably it doesn't reach where the solution can rise to. It gets discussed, it gets distributed, and it never goes where it is supposed to. So how do we overcome this? One, we have seen historically a lot of progress in the way the corporate hospitals are involving nursing leaders. Wherever the organizations have involved nursing leaders in business discussions, there is a definite drift. So I think one, involvement of nurses, and not just the leaders, the middle level leaders into it, and also making it sure that they are a part of the annual operating process discussions. When the major planning is happening, at that time, if the intellect is being used, the brainstorming is being done, their inputs are taken. More than that, they also get a highlight understanding of what is the business doing, where is the cost-centered thought process for the organization, what is the long-term perspective of the organization. So instead of just following that, please do this, instead of that, they involve in decision making, they contribute, and they understand what is cost for the organization. So when that perspective comes in mind, leaders definitely go back, and when they cascade down the KPIs to their team, it definitely will be a perspective thought about what they are looking at. Second important point is understanding and engaging the nurses. Now, there should be different forums in which the communication barriers should be, when I spoke about the iceberg of ignorance, to bring it down, different forums should be used. It could be a specific nursing town hall, or it could be department meetings only with nurses at department levels, going over there and understanding. So ICU nurse problem will be different than that of an OT nurse problem, and so on and so forth. So when that communication is there, smaller groups are involved, there definitely would be better solutions which would come down around. Thirdly, using technology, wherein manual documentations are being brought less down, and efficiency is increased by reducing the effort of the nurses, reducing the duplication of the activities with the nurses too. It helps. And involve the nurses in the change. Decision making, when it happens, it's important that in all major committees, in all discussions, nursing is involved into it, and it requires then to empower them, invite them on highlighting the concerns, right? And probably rewarding when some concerns have been brought in, which really brings a lot of difference to the organization perspective. That should be rewarded. Indicate problems before they become systematic. So this is something which a Toyota chairman said when this concept of ignorance of iceberg was said. Go see, ask why, and show respect. So very simple ways of making sure that the frontliners are involved into these day-to-day functions. So probably this level of thought and this level of involvement will definitely help in bridging up the gap which a nurse faces in communicating and bringing up the problems which they face day-to-day basis to the leadership.
Wow, that's a whole lot of thoughts around how we can address this. There's a whole lot of thoughts. So I heard that leadership, being seen and heard at the front line, involving them, right? And being there. So I kind of recollect, I don't know which system it was. In abroad, this is a concept called leadership walk around. The CEOs actually taking time to walk around, not to meet the leaders, but to meet the front line, asking them, what is the problem you would like me to fix?
Right.
And I heard that the CEO had a secretary who will actually note down what are the feedback coming from the frontliners, and when he comes the next time, the same thing will be opened and it will be asked whether it was fixed.
Yeah.
So a simple thing like this can bridge a lot of gap.
Yes.
So I'm not going to talk a lot because I can talk a lot of things around every topic, but I would like to move on to Bindu to say, Bindu, the expectation, to involve the nurse leaders into the business discussions, they should be there in the annual operating plan. It kind of takes me back to my time when I started in Fortis. They wanted me for everything, but then I will not be there when the discussions were there. So I had to tell one day, I'm not doing anything, not made part of anything, so I'm not going to do anything. Even in the slightly, rebellious manner, that if you don't involve me when you want nursing to do something, why should I be? I had to do that. This is long time ago, right? And today I'm very happy to see that a lot of nurse leaders, they are there. They can contribute to the business discussions because I personally believe if a nurse leader is not understanding the business of healthcare, they only understand the care part of healthcare and nursing, we are not going to impress upon the business leaders that nursing is a revenue center. you know and in my career I had to do multiple things to show that involve nursing you can save money, involve nursing you will find out where the leakage is happening. So we had to do all that. Now, Bindu, I would like you to reflect upon that. Are our leaders actually ready to take that spot of being with the senior leadership, and what is that we need to do? Because if we have to reach there, because it's not the question that Sino and Bindu is able to be there on the table. We are talking about the larger healthcare system, especially the corporate hospitals. Not all the hospitals, they invite the nurse leaders to be part of that annual operating plan or the business, that as discussed in the board. So what are your thoughts that how they should be prepared? Are we there, or they should, build their skills? How is it? How do we actually become the economic power?
Thank you, ma'am. So, are we really aware of the economic impact that we have in the patient care and in the organization? Some of us maybe, but a large chunk of the nurse leaders probably are not aware of. Basically, because they spend their entire day firefighting, trying to, rescue patients as well as nurses from situations, and days pass like that. So they probably do not give much thought into that. But I saw in my experience, in my previous organization, the nursing head was part of the monthly business review meetings. So that gave me a lot of insights into how the finances are displayed and analyzed and then concluded. But the idea is that whether the organization includes us, because in India, in our country, it's actually a far-fetched idea. No matter how big a corporate hospital one works with, this would still be somewhere in the horizon. But we can, from our own point of view, make this happen. Say, for example, any hospital becomes famous initially with the consultant's name, with their expertise, and then patients do come in, and then there is a, once patients start coming in, which is the team which is able to retain these patients is actually the nurses. So the patient loyalty to a hospital is basically controlled by the quality of nursing care that is provided to them. So this is actually an indirect measure of the economic impact, or probably the major economic impact for an organization. Now, how do we get patient loyalty developed towards this organization, and how can we get this retained or sustained? That is where we need to have skilled nurses taking care of patients, which is amiss grossly in today's work environment due to various reasons. So the first point in this matter I would suggest is that the leaders be in a compassionate leadership style with the nurses. Like Sino happened to mention that only 4% of the actual events that are occurring or which are, mishaps, or which are supposed to be omissions from their daily activities, that we will come to know. The bedside, the clinical nurse would know 100% what is going around, but then the higher authorities, as we go higher and higher, the percentage of that knowledge comes less and less. So how can we solve this? Because these shortcomings is what we need to address to make the nurses work efficient and time bound. The best way is to have, in fact, middle level managers daily huddle meeting with their staff and be available there. What tendency that I see is that my clinical exposure actively in a corporate hospital is just about 8 years now. But in this 8 years, what I have noticed is that unlike doctors, nurses, the higher they go, the farther they go from patient side. So which makes us unaware of what is actually happening. What are those inefficiencies that we need to plug on time? One simple example I can say here. The basic procedure for a patient when gets admitted to hospital is cannulation, the first thing. The nurse tries. She didn't get through. Now what she does? She calls the senior. That senior is not supposed to be doing this. That senior nurse has something else to be done at the time. He or she leaves that work aside and then comes on to help this. So there is a time loss. Every organization measures time as money. And so this is how, if we look at each and every procedure that happens in the context of nursing practice, if we have an involvement of higher nursing personnel into this particular procedure, then there is a time loss, and indirectly there is an economic loss there. So what shall we do? The first thing that we need to do is to plug all these loopholes. That means a nurse who walks into our hospital, a nurse who is appointed into the organization, should undergo a thorough induction and a thorough hands-on training before she or he is discharged into the system. We may wonder how long, and how many days. Isn't those days counted economically? Yes, those days are also counted economically. Then we have to look at how long will this nurse stay, so that this initial 1 month of our training has not had a major negative impact economically. So then it comes as, just like patient loyalty, nurse loyalty also to the organization. This comes into play. So my point here is that specific trainings tailored to the departments, like we have tracheostomy care, one another situation I would, because I frequently encounter this. As soon as a patient is on tracheostomy care and discharging from ICU to the floors, the consultant calls me and tells, "Madam, I need 1:1 nurse." What is the reason? They don't have confidence on the nurse on the floor, because they have developed a feeling that ICU nurses know the best, and the ward nurses, like we have posted nurses in the wards who are less competent. This is what they think. But the training remains the same. So what did I do for this is created a pool floor-wise who can take care of tracheostomy patients along with 1 or 2 other patients. So this took us time. It took nearly 3 years for me to set right different pockets of specialized needs to be addressed by specially trained nurses. If we can do this, I think nursing can be easily seen. It will be visible as an economically very viable and productive team.
Great, Bindu. I think there's a lot of thoughts. So what I heard is the leaders need to step up their, ability to understand the business of healthcare, and nursing leaders, the mid-level nurse leaders, to be available for the younger ones, and a very robust, induction program. So I think what I would like to talk about the induction program, because induction program probably has been the most misused word, because everybody thinks, spending 9 days or 1 month or whatever is the induction program. So once the same feeling was there in Fortis also when I was there. But anything that we do has to be outcome based. So I used to tell my educators, don't tell me how many hours you train the nurses. I want to see on the ground when I go for rounds. And I'm very sure the leadership also wants to see results, right? At one point of time, the CEO I worked with, he suggested to me, Tankam, if you create a pool of excellent nurses, smart, critically thinking and everything, I will pay the differential. But me as a leader, I couldn't take the offer because I have to run a hospital. So I cannot create premier nurses in one ward and, pay them separate. So it didn't make sense that, I will be upsetting all the other nurses. I'm sorry. So when Bindu mentioned, where there is a problem, you are creating specially skilled nurses so that the administration and doctors are aware that it doesn't matter where my patient is. We cannot make a nurse know everything in the world. It's not possible. So every problem will need to be addressed in its own merit based on the hospital. So administrators or the leaders need to understand what the nurse leader is thinking strategically. So one of the feedbacks I got earlier about nurse leaders when they go for interviews that they lack strategic thinking. So my throat is telling me I should stop talking. I should move on to Dr. Vivek. So Dr. Vivek, from your LinkedIn, I see you're very pro employee, you're very pro nursing. So I would like to know, have you, I will use, pardon my word, have you exploited the economic power of care from nurses?
So I heard a panelist talking just now, and actually I feel a lot different from the way actually what they are saying is in a way right, because different healthcare systems, different hospitals work at different levels in empowering their nursing teams. And the question you asked me about how have I exploited my team, I think it's not exploited. I've actually abused the nursing support all the time. I can confidently say that I take the help of them in every initiative, every strategic decision. Our nursing teams are involved in our monthly MBRs. As a matter of fact, I can tell you, we have our group MBRs where every hospital head presents 3-4 years back, used to present every monthly MBR. And in one of the MBR meetings, I said, no, this time I won't present, my nursing head will present. I can't tell you the number of queries and WhatsApp messages I got. Are you sure, Dr. Vivek? Are you not presenting? I said, no, I'm there behind her. So, and I can take the name. Jessica presented so well that day that I was actually impressed. She did a lovely job in presenting the hospital MBR. But that's something we need to do it at all levels. At our group, if I say Dr. Clara, or if I see Jessica, Judith, Jessa, Jisa, or even Glory and Rajula, all of them are nursing leaders. But I'll tell you where sometimes I feel a gap in them is that they are not assertive. They do not say their way. They get the platform to come to the monthly MBRs, understand what's happening. But I can tell you most of the times, except maybe Dr. Clara, rest are all silent spectators sometimes. I think they hesitate, and that's the responsibility for us as leaders across, not just nursing leaders but business leaders also, to give them that empowerment. They should not be hesitant in asking any question in openly to the business leaders, because look, it's an understanding process. They feel worried that I'll be laughed upon, I'll be questioned, and I think that hesitation should be dropped. If you ask me what is economic powerhouse, the economic powerhouse is when a hospital or a corporate group functions delivering exceptional financial performance. And that's economic powerhouse. But all this comes from where? It comes from your clinical excellence. It comes from your service excellence. It comes from your operational excellence. And if you look at clinical excellence, yes, doctors are there delivering clinical excellence. But who deliver the best clinical outcomes in the rooms and the ICUs? It's the nurses. They deliver the clinical excellence due to which the patient gets discharged faster, reduced stay. When you look at service excellence, what is service excellence? The patient satisfaction scores in a hospital. I can tell you every patient who goes satisfied from the hospital gives you a 10 out of 10 or a 9.5 out of 10 or a 9 out of 10. It's all due to nurses that gentle touch that they give in the rooms or in the ICUs, calling the patient by his name and attending to his small needs is something which is so very important in getting that scores of service excellence. And lastly, if I talk of operational excellence, all of you have just spoken, but I can tell you how nurses can contribute a lot in reducing inventory, controlling cost, revenue audits, Mr. Devan just spoke about. There are a lot of ways the nursing can help in reducing cost, driving efficiency. All this ultimately leads to a financial performance. And when I see my nursing teams across, and I can tell you, I'm someone who has always believed that it is them who make me stronger and stronger. So if the hospital is able to deliver excellence in financial performance, it is all because nurses play a large part. I won't say the only people who play a part, but nurses play a large part of the healthcare ecosystem. More than 50% of our staff being nurses, they contribute towards everything. So whenever we plan our strategies, whenever we have to plan our plans, annual goals, AOP plans, I think nurses form an important part. There are times when the nurses have actually given me ground level feedbacks about what's happening. Then I go back to my office and I'm able to correct it because I know I can trust them. Whenever the nurse gives a feedback, I know there is zero motive in it. It is a clear motive to either improve patient care or to ensure that the hospital's leakages are stopped. And that is how small the nurses look at it. But I can tell you, it gives me at the bigger level a much bigger perspective to look at them. So any initiatives, I think we should encourage our nurses to be very assertive, give them empowerment, and I'm sure economic powerhouses every hospital can become with this goal, because they form the largest chunk of our teams.
Muted. I was coughing, so I muted myself. So, Dr. Vivek, I did not expect anything else from you rather than your own story of doing your piece of, empowering nurses. I have heard this through mostly through your Facebook, post and LinkedIn. I keep track, and I know that you are trying to do what needs to be done. But that is an one piece that is happening in the larger ecosystem. But you, by sharing this, I hope that more and more people will get motivated to actually exploit, or as you said, abuse nurses, because I think that give them the opportunity to co-own the financial outcome of the organization, they will rise up to the occasion. I am very, very sure.
Very
And
true.
but for that, maybe they need to be equipped with the knowledge, what is required, so that they understand the business of healthcare. Sometimes the nurses are trained to be all heart. So they're all heart. They feel for patient, they feel for nurses, they will cry for nurses. So I always give a tip to all the nurse leaders. Don't cry, go and cry for nurses in front of your bosses. Cry for patients. They will listen, because nobody can say, don't worry about patient. Okay. But only thing, the cry should be based on data and numbers, to say that how my patients are getting harmed by these data. So it is very important. I just want to give a shout out to all the nurses sitting here. There are many who are good at the numbers to understand, but it's very important. How does one number speak to the other number? This is important. Please, when I came to Fortis, I never had to worry about, money or inventory at all. But once I came to Fortis, I realized, oh my God, I need to learn fast. And when I used to sit in the business review meetings, at least, so I learned all that Excels and terminology from there, and I didn't want to look and sound dumb. So I started educating myself, and once even I realized I have an opportunity to save money in OT. So I did that, project, and the money was saved. So what happened? What was the result of that one activity? I was called for meetings. And then when something is required, they look at me, ma'am. So that means trying to look at me to see, can you do something? So I have a lot of stories where I could stop the leakage. I found out what is wrong in the HIS, which was leading to some billing not happening. So all those stories are there. But I am very sure no leader should ever give up an opportunity to ensure that you are able to tell your leaders that we are good at giving care at the bedside, but we are also very good at contributing to bottom and top line. This is very important to showcase. We need to rise up to the occasion. You may not find a Dr. Vivek or a Mr. Dev everywhere because we can't choose bosses, no? So, but then assertiveness, as Dr. Vivek said, is very important. And I have had nurse leaders who are very happy to be reporting to the medical head, because the medical head will then go attend the meeting and manage the nursing. So I'll ask them, why do you report like that? You should be reporting to the top, because that is the one thing that every organization should do, that nursing is a separate discipline and the nursing head should be reporting to the top boss. That is the way positioning is first important. And for that positioning, my reach out to all the nurse leaders here is, make yourself so good that they invite you to report to the top boss. Don't hide that I'm okay, because then what happens, you go and report to your medical head and finish the story. The medical head will manage. A lot of nurse leaders I have seen, these are candid conversation, so I'm being very, very candid. So I need to go to Mr. I'm so sorry. Miss Indrani now. She had been a HR head, and she has won the HR head, and she had been in the hospitals. So I'm not going to make the question very specific, Indrani. Listening to all the four panelists. Meanwhile, the second round of questions I'm not going to ask. You people are going to ask to each other. So please think of the questions that you're going to ask each other, and we will take some questions from the audience also, because I know we are going to be closing 8 by the time Indrani finishes. So I want to bring in more interaction rather than me asking second round of questions. While you heard each other, you may be having some questions that you would like to clarify or ask. So I would go by each one of you. You can address the question to anyone, doesn't matter. Let it be as candid as possible, so the audience who are here and the recording, which will be seen by many more leaders and nurses, they can understand, and they can take away something from here to say, this is where I can start working as an individual. And like I always say, let's not try to boil the ocean, let me try to boil my cup of tea. That's what I usually say, that you make a difference where you are. So Indrani, what's your take after listening to all of them as a HR head, not as a businesswoman?
Right. No, I was nostalgic. I almost went back to my boardroom meetings, and I can confidently say that Dr. Vivek and Dev, they really are. I they're not commonplace. So their sponsorship of nursing, their identification of nursing as the largest cohort that they manage, and therefore their thoughts and the support they give, that's fantastic for IHH and for Aster, but that's not the rule normally. Okay, normally I've seen nursing leaders. I mean, I've seen both kinds, but the general rule is nursing leaders, including extremely competent, clinically competent nursing leaders, popular nursing leaders, but they'll come to the boardroom and they'll almost be silent. Okay, and I've also seen a few nurse leaders who really stand out, who you dare not call them to a meeting, or you dare not involve them in a decision that pertains to their department. The unit head can't even think of that, or the management committee can't even think of that. They know. So one is, of course, personality. I mean, some folks are born leaders, but I think I want to discuss a situation which is more commonplace, which is where nursing leaders are normally not always invited to the boardroom tables. What could nursing leaders there do? And I think two or three things that I've seen work very well is, one, by structure and by design. And HR does play a very, very important role in, number one, positioning, like Thankam mentioned. Position, the nursing head is in any hospital. They are heading 70% of the workforce of any hospital, and therefore they have to report directly to the business head or the unit head of the hospital. Number one, that's a positioning that if it's not happening naturally, HR is in a great position to get that done. Second is, yes, by design and structure, nursing heads must be called to all of the business meetings, whether it's the monthly business meeting or a budgeting meeting, any cross-functional business meeting. But equally, I think there's a role that HR plays even before that. They must, I mean, I used to spend a lot of my time with nursing, really calibrating all our Excel sheet calculators during a budgeting piece, for instance, and having a lot of ifs and buts scenarios of what happens if the occupancy is between 50%, 60%, 75%. It has to be a very agile planning. And, I mean, you can't expect nursing to be excellent in Excel sheets. That's where HR or even an analytics team, if the hospital has, must support the nursing leader in giving them those ratios and data points and helping them strengthen their argument wherever they're seeking nurse. That's number one. Number two, it takes two to tango. So calling the nursing head to the boardroom is not enough. The nursing leader must ensure, and I think one of the panelists mentioned this, that equally the business head gets to meet the nurses on the shop floor or on the clinical areas once a quarter or once a month, depending on the size and the bandwidth of the unit head of the hospital. That's where that appreciative inquiry happens on both sides, and a better understanding of the realities and a better agreement on decisions. I mean, not all decisions will go nursing's way, but at least there's a logic and the data. Also, it's easier for the nursing leader to explain to their large team. So that's one. Second, related to this is the goal sheets. If nursing excellence is not on the goal sheet of the unit head, then we are just, not walking the talk. We may say nursing is my family and the patient care and all of that, but nursing excellence has to feature, just like clinical excellence would, it has to feature on the balance scorecard or a goal sheet of the unit head. Just like, and similarly, EBITDA measure. Okay, I would actually say revenue and EBITDA measures to a certain extent must be there on the nursing head, on the CNO's goal sheet as well. That's where a point of intersection happens. And if those are not there, then really, if people are functioning in silos, then you can't really blame them. The moment you have a fairly, at least a 10-15% weightage on your EBITDA as a nursing leader, even if you don't naturally understand numbers, you will take pains to understand line by line item, all of that. And, the costs are really complex in any hospital scenario, right? And nursing would be 70% of the expenses as well. So it's a huge opportunity for nursing leaders to show even a 1-2%, let's say, optimization. And that you can do through many, many, many creative ways. You could do quality circles and put in, address a lot of efficiency issues. And quality circles are a great way. It's a team bonding thing. It's a visible thing. You can do a lot of, wall management. You can give out little prizes. There's energy and enthusiasm because young kids on the floor are solving. Okay, I mean, it's a manufacturing concept, but it works very well even in hospitals. So those are some of the things where that intersection needs to happen on both sides. And finally, like I said, HR has to help nursing with some tools. If you just leave the budgeting piece to nursing and then expect that's being unfair, I think. So you actually sit with the nursing head, help them do scenario analysis, floor by floor, occupancy by occupancy, keeping all those factors. And when you take a great sheet like that to the unit head with the logic, with the data, the unit head might negotiate a little bit, but they will appreciate that this is a data-driven job done. And yeah, I mean, obviously, if let's say the occupancy is low, the nursing head, I mean, I have had nursing heads come to me asking for manpower for full occupancy, which at that point wasn't happening. So you have to have that occupancy factor in. And it almost has to be a quarterly look. You can do a full planning exercise, but quarter by quarter, if the business is a hockey stick curve like this, then the manpower planning also needs to be a hockey stick curve, maybe at an N-1 time lag, so that you have induction and onboarding time, but that needs to be there. Apart from that, I think, I cannot overemphasize the importance of skilling, and skilling not just where hospitals or the nursing heads are organizing for their teams. the onus of skilling and staying relevant is on an individual nurse. And I think that's one area where if we can fix that at scale, it will really, it will change the way nursing is viewed in India. In India, somehow I have always seen nurses almost ashamed to be called nurses. You call a nursing leader sister. They don't like it in India. But if you, I mean, abroad, I have seen whether you're a nursing leader or the director or anybody, you are first and foremost a patient care nurse, and on your rounds you demonstrate that. So that's a little bit of a mind shift change, I think, which will come in with the focus on skilling, and skilling not just organized by hospitals, but there are lots of now online stuff available. I mean, information is not at a risk. Anybody can pick up and skill themselves, and then kick open the door and demand. If folks are not being called to meetings on the dint of your skill and on the dint of your personality, you always kick open the door and demand to be involved in stuff that matters to your population, which is your nursing.
Thank you, Indrani. There's a lot of, thoughts that someone can deep dive and get into it. But I cannot stop myself from making a couple of comments before I go to the panelists again. While they are, you're free to ask questions, or you're free to make questions, free to make comments, because it's 8 o'clock. I just wanted to respond to Indrani's, the sister story, So I keep thinking that, when someone calls you sister and brother, I think there's a little bit of loss of professionalism there. This is my feeling. And many years ago, I remember when I joined Fortis, the chairman of the Fortis, he called me Nurse Thankam. So 1 second, I was like, what is this? Nobody called me Nurse Thankam before. So it's like I had a mixed feeling whether he's trying to respect me, whether he's trying to do what, So he's read all that on my face and he said, I will call a doctor, and you are nurse by title. So with all due respect, I'm calling you nurse, because that's what is the system in UK. And today there is a bill in the UK Parliament which is going to ask for the protection of the title, that the nurse title cannot be used by anyone other than a registered nurse. And I think yesterday or day before yesterday, there was a advertisement where they are saying 20 months of training to make a medical surgical nurse. I sent this to INC president and I said, what are we going to do about it? So he said, we are talking to the state, not anybody can wake up and start doing a nursing course, right? So everything needs to be protected. That is also important. Why I'm talking about this here is, it's not so easy to fix everything in India. While we are trying to fix something, I used to use this expression, I thought I made all the right notes and I'm there at the end of the rope. Then I see, oh my, that note is gone already. I'm back to square one, trying to make that note. So these are my experiences. So that should not deter us from moving forward. We should take a proactive and a futuristic approach, and we should have more such discussions so that more nurses can feel empowered and think that how can we build our own skills. And one more thing I would like to give a shout out to all the nurse leaders sitting here is that in Indian setting, my personal experience, if you have the clinical knowledge, you get a lot of respect from the doctors. If you are only a nurse leader who only knows to manage the manpower and pull in and pull out and, just give some report, that's where it will stop. So, but if you are clinically sound, you can ask the right questions to the clinicians. Then they will start respecting you. Then that respect percolates to your team. It is very important for the nurse leaders to remember the very powerful role that we play, that how others, it is not that easy. I know that I had my own battles that I had to do while I was the nursing leader. I understand. But one thing I learned, the clinicians, they will respect a leader who knows the clinical part. You don't need to become an expert, but you should be able to ask the right questions. So I rest my observations here. So I'm going to now ask the panelists who wants to go first.
I
And
can.
we can even have questions from the audience, just to
I'm not
note
seeing.
them.
They need to put it in the chat box if they have.
Yeah, yeah. Audience questions
So
you can put in the
meanwhile,
chat box.
yes.
So yeah, just to add where you have stopped, right? I wanted to just take a quote mentioned by one of my very good friend, a very senior clinician. He said that behind every successful doctor, there is a fabulous nurse. So that's what he used to say. His name is Dr. Maharoof Raj. He practices in Calicut, Kerala. So he says that, any doctor to become a successful doctor, a good clinician, nurse gives so much of inputs, a good nurse, so much of inputs to make a good doctor. So similarly, now after hearing Dr. Vivek and a lot of appreciations I can see in the chat box, that, behind every successful nurse, there has to be a good administrator. I think that formula we can formulate here.
Yes.
So thing, and but just one thing, last time when I was attending the Anicon, there was a suggestion from the team saying that the Astra had actually announced a Astra Global Nursing Award. So people were asking why you have done in UAE and the next time in UK, why not India? So this time, happy to announce here that the awards are going to happen in India.
Oh,
So,
wow.
so,
Fantastic.
and we will hope that, an Indian wins that award. That's one. And there are things I think, I was surprising to hear that, a lot of organizations are still not using or collaborating with nurses or using them in taking strategic decisions is a big surprise for me because, I mean, Dr. Vivek has made it very clear that his all his activities nurses are part of. As to we have every month the IBR, which we call the business reviews. Nurses are part of it. We have a core committee in all my units. We have a core committee where the nursing head is a member. In the budgeting exercise they are members. So I'm surprised to note that a lot of hospitals still are not using the expertise of nursing leaders in developing these strategies. Very, very big surprise for me. And one different thought of a finance guy I've just wanted to share here is, just a different thought where somebody was saying that, a 20-year-old nurse in the hospital compared to a 5-year-old nurse in the hospital. The 5-year-old nurse can do 90% of a 20-year-old. So why should I pay more for a 20-year experienced? I'm sorry, talking about 20-year experienced nurse, sorry. So the whole thing comes in the approach of the senior nurse, right? So the experience that this person has gained over the years in taking care of the patient in terms of compassion, in terms of the skill, that a 5-year experience can never replace. So obviously, the cost saving that the 20-year experienced nurse can bring in was supposed to be, I had to demonstrate that to the finance person to say that, okay, yeah, this is why you have to pay a 20-year experienced nurse in a hospital rather than, adjusting with a 5-year experienced nurse. So this kind of thought process are still there. People consider this kind of thought process in India, especially, and in terms of one negative side of it is the attrition. So people feel that because of the fact that the nurses are not paid well in India, there is a huge attrition, which puts the administrator thinking that, okay, anyway, whatever I do to my nurses, they are not going to stay back with me. So, what happens is that that's a vicious circle. So they say that, okay, whatever you pay, 2 years, 3 years, they are gone. But that 3 years, what they can contribute to the organization is something which many people haven't realized. So I'm really happy to see here a lot of perspectives, different perspectives. Very nice to hear a lot of things to learn. I'll also take a lot of inputs from the team which has come into my units. So that's it. I want to stop here because, I think we are already crossing the time.
Yeah.
One thing that we are doing, final statement is that in terms of Aster, we also do a talent mobility unit to unit. Somebody aspires to become a leader. We move people from unit to unit. So I was really happy to, have a lot of nursing leaders who have emerged from the places where I've worked. And also another thing is an Aster Academy that we had, where we also train them on the managerial skills. So these two things as an organization we have started developing. And good luck to all the nurses. I think this is something which we should have more discussions on, especially on the strengthening the nurses with a lot more financial information and empowering them more. I think I will be definitely will be part of that and forefront. I promise that from my side. Thank you.
Thank you. Thank you, Mr. Dev. I just want to pick on one thing that you talked about, because I must admit, I always ask senior nurses who come for interview to me, why should I take you? Why should I pay you? Why should I take you? Because as you said, a 20 years old nurse will demand X. But if she will not demonstrate, that's the word you used, demonstrate the 20 years experience, then that could become a wastage of money, right? It's very important that we must admit that. So I just wanted to make that statement, that demonstrate the value of your experience is very, very important. So always in my leadership thing, I always say, I have done maybe thousands and thousands of nurses interview in my career. And if you ask me whom did I reject more, I rejected more experienced nurses. And I have proof for that. So this is candid. So I'm not going to sugarcoat anything for anyone, because it's very important to showcase the value of your experience. With that, let me just move on to Bindu and see what's her thought. Yeah, please.
One thing about this, ma'am, there is one thing, since this is on economic impact that nurses can make, is it possible that the nurses generated revenue be separately listed in the patient bills or in somewhere in the organization's bills generated? Because this will, like Mr. Devanand said, professional independence is what makes the doctors or consultants command that fees, and their name comes up. So professional independence is not getting demonstrated by nursing in India or across the world. We consider US as the highest authority in that line of showing some independence in the profession, but it's not complete independence. Even last week, I was reading an article by one of the nurses from the US about how nursing is still not an independent profession. So is there a possibility, this is actually to Dr. Vivek and Mr. Devanand, that the nurse generated revenue be shown separately instead of, total room charge, bed charge, or any other things? When we break down indirectly, I can see even for cannulation done by nurse, there is a charge in that total amount that is being shown, but it is not for public to see. Why?
That's a very, very hard hitting
Great question.
Very, very
Great
good,
question.
very great, great idea. But I think that's already there in the bill. The only thing is that we probably will have to take it out from the bill and project it as the nurse-generated revenue. I think most of the systems actually come with the billing distribution, right? Each line item is already captured in the system. Yeah, to take out and filter it out on the nurse-generated revenue is a fantastic idea. I think that's something which you should all look at. Yeah, definitely I will try to implement that.
For it, so
We would
Thank
love
you.
to hear. We would
So
love to hear
I'll answer
that.
this.
Yes,
To some
please.
extent, I'll say yes. To answer your question, almost all hospitals capture the different procedures done by the nursing, whether it's dressings, whether it is cannulations, or a lot of other procedures which they do in the hospital. So I think it's easily there in the system. It's up to each nursing head to capture it, look into it, and then showcase it. For
No,
example, I can tell you in my team.
be displayed in the bill given to the patient
No,
as
no.
nursing charge. That is
So
what I'm asking.
I get your point, but my view is slightly different. I would not want everything to be shown that it is displayed. Nursing charges are displayed in the bills. But in my team, I know that my nurses put up a monthly trend of dressing charges collected. So many dressings done, minor dressings, major dressings. Rashmi, I don't know if she's there in the team, in the group here, but she presents it to me on a monthly basis. So I'll tell you, I would like to slightly deviate and discuss about the point that the respect should be earned. I heard Thankam talk about the nursing reporting to medical and the nursing reporting directly to the CEO. I'll tell you, I came across this problem in patient care and patient complaints in the morning meetings which I attend every day. I realized that when there is a complaint which comes to me, the nursing team tells me that we told the RMO, the medical admin tells me we told the nursing aide. And I'm struggling around who's now to be asked for, where is the gap? I need to know the gap to correct it. And one change I did was I found my nursing leader, Jessica, taking leadership and answering all questions. You know what we have done in our team? We have divided medical administration into two parts now. Jessica is the head of medical administration and patient care areas. All the junior doctors report to the nursing aide. You are asking me about or talking about nurses reporting medical, the doctors report to the nursing aide now in our hospital today in Mumbai. So that's a change. But I'll tell you, it's earned. It's not given to her because she's the nursing aide. She delivered it. She showed her work. She delivered on her performance. And she was very proactive in taking decisions compared to the medical aid. So medical today is only the back-end services dealing with consultants, their contracts, medical legal services, MRD, dietary, all that. Front end, all junior doctors, floor RMOs, ICU registrars, junior consultants all report to the head clinical services, who's a nurse. So that's the way you should earn it. And that's the way I believe nursing will go forward. The nursing leaders like us will have to empower our junior leaderships and our teams below to come forward and give them the backing. They'll make mistakes. I'm telling you, they'll make mistakes, but it's up to us to give them that backing and support till the time they come up, because we all learn by mistakes. As a doctor, I'm not a businessman. I learned business because somebody gave me an opportunity to get into this. If we give our nurses the opportunity to understand business, they can deliver wonders for us.
I have a point. This is just off track, just because we are discussing such an important perspective.
Yep.
Now, Bindu mentioned, can we have a specific area where the nursing charges can be appropriated? Initially, when we all started the discussion, one of the challenges which we all mentioned was the nursing salaries to be increased. Now, if you look at a clinician, clinicians do have, an appropriation in terms of number of patients that they see, and there is a direct calculation. And we also know that the way in which their packages are being done, like, after a number of patients, then, we have a cut, it's not a direct salary. There are number of patients above this, they get a revenue around that. So can there be a time where, because I don't see any other way in which the nursing salary solutions can be brought into, but if there could be an appropriation of the number of hours a nurse spends on a patient and the activity that she does on a patient, and there could be direct revenue which a nurse can be given in an Indian scenario today. One, there could be, definitely an improved salary structure for a nurse. Secondly, the attrition that we are facing to a great extent, where people are, there's an exodus happening, basically because there is a good salary which the people get abroad. If they can be given that recognition through, this economic, the financial benefit that the nurse can get in the current scenario itself, with time, if that sort of a calculation can also come in picture, it definitely will, take care of a lot of things. There would be nurses who would be willing to do more hours because they, they themselves get the benefit of, spending that much of time and hours on a patient. That sort of a scene, is it anywhere visible in future in our healthcare currently in India?
So that's a question. That's a
Yes,
question.
that's a question. That's a question.
That's a question in itself. So I'm going to add to that a little bit, because a very what you call is a very disruptive thought.
Exactly.
One way of looking at, making sure the nursing charges are reflected and given to the public, it has got one connotation, that the public start viewing nurses differently. Because right now the public may not be looking at nurses as the main, team member of delivering care. So they usually say, doctor is telling, and these nurses, they carry out, that's the kind of mindset. So these are all, candid conversation we are having. So when you start putting that, Dr. Vivek, you are very right. The nurse leaders should know what is the revenue the nurses are generating. Maybe that is the first step to start. And then say that, how do you show that in a bill? Separately, not to hide it inside the room charges, but rather put that as nursing charges, which are, the line items can be done. It can be done, in many different ways. I'm very sure the financial wizards like Mr. Dev and all can come up with an idea that this is how we can do the nursing charges. Now, coming back to what Sino thought, these are disruptive thoughts. I'm just sitting here and thinking, what can be done? So I'm going back to Bindu's problem of tracheostomy. Okay. So now, if there are specially skilled nurses who are going to deliver tracheostomy care to a tracheostomized patient outside the ICU, because ICU, maybe you are giving ICU allowance to all the ICU nurses, but outside, if you start monetizing that care that is given by a specially skilled nurse, then Bindu will not have any problems. They will be running after her saying, "Ki, get us trained, why we are not being assigned to such patients." So I think all of us together, we are coming up with a lot of disruptive thoughts. And I think I'm looking at, Dr. Vivek and Mr. Dev to tell us that, we want to share this story now. A very disruptive thought of Dr. Vivek, which he executed, making a nurse leader, head the medical services. I have not heard of that before, and it is working. So maybe someday we would like to hear that story from both of you. I mean, you and Jessica, to see that, my only content will be that when a nurse leader becomes a medical head, that person should not become the reason for divide between doctors and nurses. That leader should not move away from nurses. That is my humble submission. I'm not very sure whether it is, there is a possibility, because I can see it happening, because it happened with ICNs, infection control nurses. When they started reporting to microbiologists, they ran away from CNO. They say, oh, now we belong to doctor microbiologist, so we are something special. Quality nurse, so at least as long as I was in Fortis, I said no, parallel reporting, because nurses hold the maximum infection control practices. So she should be reporting to me also. It's a parallel. So they report to me administratively, otherwise they can report to microbiologists to work with them. Same thing can happen with the quality nurse. Quality nurse goes under the quality head, and then they have a little crown on their head. Yes, I am being very candid. Like little crown, they don't even give a hoot to the nursing head. They say, oh, I am this, Am I exaggerating, Bindu and Saino? It may not happen in your system,
Very
but it can happen.
because
So
they feel they are more powerful when they are under.
yes, so there is
Absolutely.
a little bit of risk sitting there. So I'm just telling Dr. Vivek and Mr. Dev, when you give that idea, never give that perception that nursing is any less and medical. There's a possibility. There's a possibility. Am I right, Dr. Vivek? It can happen.
So you are so right, but I'll tell you that all depends on the leadership. It's for 1.5 years. I did it as an experiment because I wanted the front end to be under nursing, but I couldn't position it as nursing. But somebody as a capable leader came forward, I can do it, and I designated it as head of clinical services. But today, after 1.5 years, I can tell you my only job was to support, because I know initially doctors did come to me, and I've expressed it in some forums earlier, and they've told me, how can we report to a nurse? And that was my duty to tell them, how can you report to a non-doctor CEO also many times? So look, you can ask multiple questions, but don't look at her as a nurse. She is a leader. She has done a business administration. She's got a nursing background. It will help you because she's a clinical leader. And look at it from their end, that if the nurse is there heading everything, she will give you backing like anything in your programs in the departments. So it's actually giving results, because doctors have now started accepting it, and they have started relating, because they now know their work gets done. In fact, one doctor who has come to my office to tell me, what a wonderful change you did. Today, I just have to call her and I get my job done, because earlier I used to tell the medical admin had to tell the ground floor nurse, and then my work will be taken care for the patient. Today, it's here, directly it goes down to the ground. So actually, I'm not saying it will work everywhere. It depends on the person's merit. And that's how it is. It is not to be demanded. It is to be earned. And that's how I would leave it.
So I'm just restating everything to all the leaders sitting here. The word that is coming again and again, it needs to be earned. So I think the aspiring leaders have to equip themselves with the knowledge, skills, and attitude. I love this KSA, Kingdom of Saudi Arabia. That's not the one. It is knowledge, skills, and attitude to rise up to that occasion, right? And my humble request to all the nurses will be is that we are talking about empowering nurses, but nurses, when they get into something else, they don't even try to tell that I'm a nurse. I have examples where people have gone beyond nursing and they have become something. So I have to literally needle them to say that, you are a nurse to start with. But if you go abroad, when you look at CEOs and CEOs, the first thing they say is, I'm a nurse to start with. And today I am a CEO. So what happens? All the future nurses, they're listening to them. As today we have only few people who have risen to that, positions, but I know of at least couple of them who don't want to make that statement. It's very important to make that statement when a nurse actually becomes something else. I'm not alluding to anyone here, particularly Jessica or something. The other conference, she was very upfront to say that, I got that opportunity. So I'm not talking about any particular person. It's just that I'm just talking to all the leaders here. When you get an opportunity to move out and do something else in healthcare, make that a point to say that as a nurse you can do this also. Such wonderful stories are required for the future generation of nurses. We have to attack it from, I don't know how many sites, I have no idea. Wonderful, discussions that came our way. So Indrani, we are 8:26 and Mr. Dev has a hard stop. I have a hard stop. Dr. Vivek also has a hard stop, though he's smiling. And I'm sure that if Bindu and Saino has put in a long day, they would like to get back. So Indrani, would you like to say
Yeah,
that?
I just have one word that I think we need to do more webinars to take some of these ideas into, actionable insights. There's so much of wisdom residing in both the panelists and the audience. I'm already getting a lot of messages. I think we must do more webinars around these topics of cross-functional skills, etc. So on that note, I think thank you very much once again to every panelist who's taken time and who's really spoken from their heart. I think we've had a no holds barred, very honest discussion. And that's the intent of our candid conversations. For folks who joined in late and missed the presentation, in case you're interested in the calculations and numbers demystified, which is the analytics skills for nurse leaders, keep a watch for on our LinkedIn handles. I've also attached a file on the chat box. For folks, special 20% discount for those who have attended the webinar today. So you can drop in a line on our email or on our WhatsApp. With that, Thankam, over to you for the goodbyes.
Thank you. Thank you so much, Indra. And about the training, I would say that this is actually a very basic requirement for any nurse leaders. And I always say the ward in charges, the unit heads, you call them manager or unit head or ward in charge, they must understand this piece. It is very important. Because that's something I learned when I was the nursing head. I had to train my ward in charges to get the result that I wanted so that they are aware. So those are the stories I actually share, when my nursing head will come and say, this is my consumption last month, and this consumption is like this because of this. They became so smart so that I don't have to ask any question to them. Why your consumption? And even today, I know on my fingertip, on an average, ICU patient will consume so much for the common items. I know ward patient. I don't know how it has changed now because 12 years of Fortis had been totally into numbers for me. It was very important. I learned it that number is power and knowledge is power, because when I was the first nursing head, I started keeping numbers. And by the time we were 6 months operations, nobody had kept those numbers. Average length of stay for a CABG and many such things. It all came later because that was the first hospital. There was no previous anything there. So suddenly every time my CEO will be asking me, ask Tankam. So she'll have some number. After some time, nobody started asking me because everything was, taken care of. But then I started putting in a lot of numbers which nobody asked. But I kept it with me. And when the CEO changed, when the first CEO came, he asked me a question. And I knew because the next CEO was the HR expert. He asked me a number on manpower. So I had to take all the data, dashboard I had. I just have to clean up my Excel because till then nobody asked. I went next day for the meeting, and I knew from the expression that he never expected me to come with an Excel and explain like a proper business person. So he was like, oh. You came, so I could see that expression, and that was the benchmark, I think, inside Fortis. So I'm not saying I know everything about Excel, but I pride myself. I invested a lot of my time to learn how Excel can work. But ladies and gentlemen sitting here, today's date, there's a lot of technology which is available. And I pride myself that I trained myself in AI. So my productivity has increased. So I'm giving out the little secret only to motivate all the youngsters. If at 64, I can continue to learn, all of you can invest a lot more, assert a lot more, so that the leaders in the healthcare they cannot neglect you. Make yourself so powerful that nobody can neglect you. That's what I would say, because otherwise we can go on and on. But definitely, I will request Dr. Vivek and Mr. Dev to pay attention to this billing thing. And if something happens, please let us know. We will call you for next round of candid conversations. Can we do that?
Sure.
Okay,
So,
so I expect
Thank
me to touch base with you. Hi, what's up? What is happening? Can we have another conversation? We are going to do that. Okay. With that,
Thank you.
8:31, ladies and gentlemen, a big thank you to Saino, Bindu, Dr. Vivek, and Mr. Dev. The discussion has been very, enlightening and very challenging, because we have not closed with any solutions per se. Anybody sitting in the audience, if you have any path breaking thing that you have done to make sure nurses are treated as a revenue center, not as a cost center, and nurses are the economic power of healthcare, do drop us a mail or a message, and we will see between me and Indrani how can we capitalize on your experience, and how do we spread that message to more people in the corporate hospitals. We are very candid that we are talking about corporate hospitals. We are not talking about government hospitals. With that, thank you so much for such a wonderful discussion. And I don't know,
Ma'am.
much more can I say. Thank you.
Thank you. Thank
Thank
you,
you.
everyone.
You all have been
Thank
very,
you.
very
Thank you
candid.
so much.
thank
It
you
was a
for
wonderful
being a
evening with all of you.
wonderful
Thank you so much.
moderator. Thank you so much.
Thank you to the moderator
you.
and to all.
Thank you all.
Bye-bye.
Thank you so
Thank
much.
you.
Bye and
Bye.
take
Bye.
care.
Take
Bye.
care. Bye-bye.
Thank you, ma'am.
Yeah, ma'am.
Thank you all. Yeah, the recording will be updated on Signia Healthcare. Bye.